Um, Good afternoon, everyone. Thank you so much for joining us for our first ever joint event of the National Paediatric Diabetes Audit and the National Diabetes Audit, the Adult Audit. My name is Holly Robinson and I manage the National Paediatric Diabetes Audit. And we were inspired to host this webinar today after a fantastic presentation by Dr. Jackie Elliott, who's presenting later on today at our national conference in January. And one of the things that Jackie said that really struck us was that young adult colleagues or adult colleagues might not know about the improvement trajectory that paediatric diabetes has been on over the last 10 years. And there are lots of things about young adult practice that would be really useful for paediatricians to hear, paediatric diabetes teams to hear before young people transition to their services. So we thought we really need to start bringing young adult teams and paediatric diabetes teams together in these events to learn from each other. So that's what we're going to try and achieve today, very briefly over our lunchtime. We've got quite a lot to cover, so I won't waffle on for too long. But first, we're going to hear from Dr. Jackie Elliott, who's presenting a paper that was produced using data from both the NPDA and the NDA. Then we're going to hear from Professor Justin Warner, our clinical lead, who is going to present on inequalities that we've found to be quite enduring in paediatric diabetes outcomes. Then we've got Dr. Fulya Mehta, the National Clinical Lead for Children and Young People's Diabetes from NHS England, to give us a bit of a programme update. And then we've got a wonderful case study from colleagues at Mersey and West Lancashire teaching hospitals to talk about how they have been transforming their transition programme. So lots to cover. Hopefully this will be one of the first of many events that brings paediatric diabetes teams and young adult teams together. The Q&A is enabled, so we're going to try and make time for a couple of questions after each presentation. We will record this webinar, so if you have to run away and do something and you want to catch up, you can do that. But yeah, that's enough from me, I think. So let's hand over to Jackie, if you want to load your slides, Jackie. And unmute yourself.
Yeah, can you see the opening slide, Holly?
Perfect.
Yeah, apologies, I'm in a shared office, so let's hope there's no emergencies. Okay, so thank you very much for that kind introduction, Holly. So yes, I've spoken to adult colleagues before and showed this slide. It's before COVID, so probably 4 or 5 years ago, and there was nobody in the room of about 100 people that had seen the slide up to that point and were aware just how much outcomes had improved in the paediatric world. So congratulations to our paediatric colleagues. And not only is it the result, but I think it's also having a really high quality audit process that everybody joins in. It really is mandatory, and people then support each other, and there is some peer pressure, and overall this has really driven down variation and therefore mean and median HbA1cs. The same, I'm afraid, can't yet be said in the adult world. We're just starting to make some very small movement, but no consistent changes in the same league as this. But then I'm not a paediatrician. In Sheffield, we receive young people from the age of 16 if they're more mature at that age. And so what we see is older teenagers and young adults. And as you can see here, the picture isn't quite so rosy if you've got older children, in that their HbA1cs are higher, and especially if they've had a longer duration of diabetes. And in 2020, when everything went a bit crazy, but more so in the adult world, we know that over 9% of children didn't have an HbA1c, but it did vary an awful lot from region to region, and the children's services were affected far less than in adult services. And so I'm guessing that presumably some of the higher HbA1cs and some of the older children might have been missed, and potentially we're not quite sure if we've recaptured those people. So there was an audit published of adolescent outcomes, and one of the themes of that was thinking about HbA1cs in particular really deteriorating from the age of 15. But some of us got together and thought, well, let's just get the whole picture. So from what age does HbA1c really start to deteriorate? But more importantly, at what age does it also start to recover? And so we've combined data from the paediatric and from the adult audits over 3 years. The paper is now in print in Diabetes Care. We've been able to combine data about admissions, and we know that all the paediatric units submit data, and even if not quite all the specialist adult services do, then we know we've got good capture of young people from data from GP practices. And so overall, we've got data on over 90,000 people, so a very robust study. And what did it show? Well, it showed that in the UK, when we looked at the latest valid measurement within a 3-year period across these ages, you can see that it does start to drift up from a very young age and become statistically significant from the age of 9. And whilst the boys do peak with a 12 rise in HbA1c, for the girls, it's even higher. And more importantly, I want you to look at what happens over on the right-hand side. So it isn't just a blip. It takes a long time for these young adults to really get control of their diabetes again. And for some girls in particular, if they're planning pregnancy, I think that's why the black line catches up a bit compared to the blue line. But you see, it doesn't magically get easier when you're in your 20s, trying to find your first job, relationships, work, and all the rest of it. And this is the best it can be. So we've quoted here the median of the values that we've got. We know that means are generally higher. And unfortunately, at the age of 19, 20% of people had not had a single HbA1c in a 3-year period. And my guess is that those people where we're missing these data points are likely to have higher HbA1cs. And so if we had data on all young people, I think this peak would be even steeper and the peak would be much higher. You'll also notice in the table I put there that the age-related pattern persisted after adjustment for ethnicity, social deprivation, and duration of diabetes. So if you're looking for the leading factor of poor diabetes control, it is actually age, not ethnicity, not social deprivation, and not duration of diabetes. Yes, they play a part, but the pattern still exists even when we adjust for all of that. Growing up with type 1 is really tough. And it does have some immediate consequences. So in terms of admission data, we looked at DKAs, and you can see that these gradually rise from the age of 6 in boys, and there's a fourfold increase by the time they hit their late teens. But the rise for girls is even more marked, with an 8-fold increase in rates of DKA. And for whatever age you pick, the girls are more likely to, 50% more likely to have an admission due to diabetic ketoacidosis. So we know that we're storing up problems because of the higher HbA1cs, but there's also some acute problems in terms of DKAs. So we really do need to work together more, and I'm really pleased that so many people have joined this lunchtime in order to begin this journey. And when I presented at the paediatric audit, I was trying to think from an adult perspective, what would I like the paediatric colleagues to do more of? And I think it's just recognizing that there will be some missing data. And if young people are missing HbA1cs, then they're likely not getting any healthcare input, as most places do now do point of care testing HbA1cs. And obviously we counted that where it's available. And so perhaps in the paediatric world, having now driven down HbA1c, and I know there's some way to go, but also bringing a measure, thinking about data completeness so that we have less and less young people falling through the net. We know, as I said, that lots of people will be getting lost. And just in case you think, oh, I bet that doesn't do any harm in the longer term, well, there's work by Naomi Hillman in a separate analysis looking at the national diabetes adult data. And what that showed was that over a follow-up period of 7 years, if at baseline you had 5 care processes completed compared to people that had 8 care processes completed, and then look 7 years later, there was a 37% higher chance of dying. The people that had only 5 care processes were on average age 40. Those that had all 8 were average age 50. So effectively, they've lost this benefit of being 10 years younger and are more likely to die. We have to get people engaging with our services. So I would urge people to think about actually counting the safe transfer to adult teams, not just writing a letter hoping that the young person pitches up at the adult centre, but waiting for the letter to come back from the adult teams and double checking that that young person has been received in the adult service world, and making sure that all your adult colleagues know that we shouldn't be discharging anybody under the age of 25 years. As we've shown from that graph, we know that you're likely to transition young people into our services on an upward trajectory of HbA1c. But there will be times when that becomes more difficult if it's a massive jump that's happening. And so if you could avoid times that when things are really unstable, then that might help with some of the damage limitation, and instead think more about maturity related transfer as opposed to just age of transfer. There's some people that are, very mature at 16, 17, and then there's other people at 18 or 19. You think, they're not very mature. How will they cope in a young person's service? We need to be realistic about what the adult services might be able to offer, and we know that the pump rates are much lower in adult services, difficult to capture, but somewhere around 15% of the adult population. And so we know that the young people that you transfer are less likely to start insulin pumps with us than they are with you. We've just got huge numbers of type 1s. So please, 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 especially with the advent of hybrid closed loops, do consider starting more pumps on young people, and especially if you can do this in a year or two before transfer so that they can get used to using this independently, then I think that would really help. We know that blood tests are uncomfortable, and in terms of the adult audit, we have to do a few more tests. So if we're missing lots of data, that doesn't make it easy. So if I've got a youngster sat in front of me and they're complaining of tiredness, for instance, but their last thyroid function was 18 months ago, that's not particularly helpful, because then I'm thinking, well, I don't know if their thyroid function is okay or not. And it'd be much better if you could do those annual review type bloods just prior to transfer, so that we're not needing to do the uncomfortable blood test the first time that we meet them. And as I said, we know that there is a legacy effect of poor glycemic control. And just to give you an idea of what this means, we're not talking about a long, long way off in the future. So in our clinic of about 120 people that have already been transferred, age 16 to 20, then the number of people that have referable retinopathy is about 1%. So either R2 or some maculopathy, or occasionally R3. But you can see that that massively jumps up once you get to the age of 20, 25 years. So these are people in their early 20s needing to go to eye clinic and possibly have treatment. However, for some, let's be honest, it can be a trigger to change. If we're doing the screening, then we've got a chance of finding out, do they need to be seen in eye clinic? If you're not doing the test, then you don't even get that result. So sometimes this needing to go to eye clinic, and they're getting that their type 1 is more serious, can really be a point that they knuckle down and start to give insulin on a more regular basis. So, and I know that retinal screening is based according to where the GP is, and for some of you, you'll be looking after people that are not in your immediate area. But please do chase those results and make sure that they're having them done, and if they're meant to be going to eye clinic, making sure that they attend. And then the last thing that I was thinking that would be really helpful, if this was at least broached in paediatric care, is talking about future plans for pregnancy. I've had a couple of young women in my clinic who've burst into tears because they didn't realise that they could have a family. For some reason, they got the idea that they could never have children. And so, that's not a comfortable position to be in. But on the flip side, we also know that poorly planned pregnancies is really common in type 1. So 7 out of 8 pregnancies are not planned in the way that we would like. And guess what? That rate is even higher in young women, older teenagers and people in the young 20s, and this does have massive rates then of congenital abnormalities, which makes their lives and obviously that of the child very, very complicated. And so I would urge paediatric colleagues to at least have some discussions with particularly young girls, letting them know about what's required in terms of glycemic control, that there are complications, that pregnancies need to be planned, and that things like eye screening need to be done on a more regular basis, just so that when we're seeing them for the first time and we find out that they're moving in with their boyfriend, that we don't have to start this conversation the very first time that we see them. It's not the way to really start building a rapport. We will get to it, but I'd rather just hit the second or third consultation, not the first one. Thank you.
Wow, that's brilliant, Jackie. Lots to think about there, and really useful to have some practical examples of what paediatric colleagues might be able to do. I just wanted to defend our HbA1c reporting actually and collection before we launch into Justin's. I think we lost a few during COVID, but usually I think there's a 99.9 completion rate for having at least one HbA1c, and we have usually 3 or 4 per patient in each audit year. But you're right, we shouldn't get complacent about that, and so that's why we do continue to report it and report at unit level.
No, that's great.
Per child.
I was just meaning there will be a proportion of those
Yeah,
that will have moved out of your service, and now we don't know. So in the same way as, you know, some kids we know fell out of school, and there's lots of children that haven't gone back into education. So yeah. But yes, I'm totally envious of your audit results and your processes. Well done.
Thank you. I can't see any questions in the chat. Maybe you answered everything. So we are perfectly on time. Maybe we can wrap up some questions at the end. I'm sure some will come through. But Justin, can I pass over to you to look at inequalities?
Yes, you can. So thank you, Jackie, and thank you, Holly. So I'm going to talk about data from the NPDA, and I'm going to talk about inequalities, which we've been focusing on over the last few years. So for those of you who are adult diabetologists in the audience, in paediatric practice, nearly all the children with diabetes have type 1 diabetes, or 95%. So this is really about type 1. And in England and Wales, there are about 33,000 children cared for in paediatric units, of which 31,500 have got type 1. So we really focus much more on type 1 than type 2. Jackie's showed you this infamous slide, which we're very proud of in paediatric practice, showing the median HbA1c over the last 10 years has improved from around about 72 millimoles per mole to now being just short of 60 millimoles per mole. And this improvement has been brought about by combination of lots of things, such as network working, best practice tariff, peer reviews, quality improvement programs, and the use of technology, probably more latterly. But as you can see, towards the last few years of this downward trend, there has been a little bit of a plateau. So we're beginning to think about other things that might affect this overall median H1C. And the reason we do that is that if we look at countries like Sweden, who probably have some of the best health outcomes in the world, if you look at a similar graph for them, and this is their average HbA1c over a similar time period, you can see it falling away in the way ours has done. But if you look at their average HbA1c in 2020, it was 54 millimoles per mole. So considerably better than we have got in England and Wales at the moment. And if I superimpose the trajectories for England and Wales on top of that graph, and I take it back, we've reached a point to which Sweden reached in 2013. So we're about 10 years behind catching up. And the problem with the Swedish is they keep getting better. So at some point, hopefully we might catch them. So you have to turn towards how you might think about bringing that HbA1c down. And if we look at this funnel plot, so this is the mean adjusted HbA1c for the 175 centres across England and Wales that look after children with diabetes against the size of their clinic. And you can see there's a massive variability around the average. The light blue dots are England and the dark blue dots are in Wales. And this is even after we've adjusted for things like ethnicity, deprivation, duration, and gender. But if you look at the statistical models, when you adjust for that, they only account for about 10% of the variability. So there are other things that are going on at your clinic level, which must account for that variability. So let's start by looking at some of the inequalities that might cause that. And this is the mean HbA1c divided into the 5 deprivation quintiles based on postcode, which is converted to a lower super output area to give us a deprivation score. And you can see that in each quintile there is an improvement in HbA1c over the last 8 or 9 years, but there's quite a difference between the most deprived, which are in the red, and the least deprived, which are in the blue. And there's nearly an 8 or 9 millimole per mole difference between the least and the most deprived. So that's one area we need to think about. If you look at ethnicity, you see a very similar looking graph of a downward trend in all ethnic minority statuses, but there's quite a difference. If you look at the top line, which is black children, as against the white Caucasian children, which are in the light blue at the bottom, again, there's about 8 or 9 millimole per mole difference between those two groups. So another area where we might think about focusing. If we look at the use of technologies, so we probably use technologies more than you do in the adult world at the moment, and this data is now a year old, and about 40% of children were using insulin pumps as of last year. That's probably higher now, of which about 7.5% are now on closed loop systems. But the use of real-time CGM, about 30%, and at just over 40% using flash glucose monitoring. So nearly 70, or just over 70, nearly 75% of children using blood glucose monitoring outside of finger prick analysis. Does of course all these things make a difference? So if you look on average, so these are the different techniques for giving insulin and monitoring it. So the far left is insulin injection alone, and with a mean HbA1c of around 68. And if you add a flash glucose monitor onto that, it brings it down by a couple of millimoles per mole. And if you add CGM, it brings it down to about 62. But look at the pumps. So the pumps on their own, about 64. If you add flash glucose and CGM, that drops to 62 and 58 respectively. But look at the closed loops. They're running around about 56 millimoles per mole. Now, that's not saying you should go out and put every child on a closed loop system, because it's not necessarily appropriate for all, but it is telling you something about the outcomes in terms of HbA1c. So what about the use of pumps? And turn again to look at ethnicity and deprivation. What is their take-up usage? So this is one for pumps. So on the left is the ethnicity breakdown, and on the right is the deprivation breakdown. And you can see there's much higher usage in white children than there are opposed to black. And if you look at the most and least deprived areas, again, there's quite a difference in the usage. And if you look at real-time CGM, you get a rather similar looking graph, with white children much more likely to be using it than black children, and again, quite a difference from most to least deprived. So what about other outcomes? I've focused on HbA1c, but if we look at DKA admission rates as well, so this is we just finished a 5-year longitudinal study of DKA admissions. This is not those at diagnosis, this is DKA after diagnosis of type 1. And you can see there's quite a difference in the deprivation quintiles over those 5 years. If you break it down by ethnicity, you get a similar sort of looking graph. Again, the black children have a much higher rate of admission than do the white children. So I've got 4 bullet points of conclusion, and I've got a few slides just focusing on what we might think about in terms of how we can change this this situation. So I don't think there's any doubt in saying there are dramatic improvements in clinical outcomes for children and young people with diabetes in England and Wales over the last year, and it's approaching that seen in some other countries. If you look at DCC studies and Audit studies, that change of about 10 millimoles per mole over 10 years would reduce your risk of a microvascular complication by about 40%. So it's quite a big change. There still remains excess centre variability and variability in depending on where you live, your ethnic status. The use of technology certainly seems to be associated with lower HbA1c, but there's poorer usage in certain ethnic groups and deprived groups. So inequalities remain a problem. So what can you do about it? So this is one of the NHS England policies. This is the core 20+5, which we're probably familiar with. So this is the approach designed to support integrated care systems to drive targeted action, and this is for children. So you target your lower deprivation quintile, the bottom 20%, and these are all the different chronic diseases of which diabetes is in there. And it suggests if you were to put them all onto pumps, you might make quite a difference to that 20%. So this is out there already. I learned the other day that Diabetes UK are beginning to look at contacting centres to try and understand barriers to clinical care, and they're gathering insights and information about technology usage, which of course I've already shown you is not as good in ethnic minority groups or lower deprivation scores, and they're trying to look at the barriers and the diversity and the deprivation around information they gather. You can, we've done some statistical analyses in the NPDA to try and see what the impact of technology might be. So this one is about DKA admissions, not a diagnosis. These are DKA admissions beyond diagnosis, and what the regression analysis should show us. So if you just concentrate on the 2 red outlined areas, so the percentage of children and young people with type 1 diabetes with an HbA1c above 80, so these are poorly controlled, having a DKA admission is nearly 13%. And if you use the model and you were to put all those children onto an insulin pump and a real-time CGM, you could potentially reduce that to 7.6%. Now, I appreciate this is a statistical model, but it's based on real data. That reduction would reduce your inpatient DKA stays from 2,300 to about 1,300, and it would save the NHS about $750,000, which doesn't sound a huge amount in the NHS budgets, but it's somewhere in the right direction. This is a piece of work that we've just completed with the Association of Young People's Health, and I won't say too much about this because it's due to be published tomorrow, in fact. So Holly and I have seen this draft, but this piece of work, which was commissioned by the NPDA, took interviews in 47 children and young people living in marginalised areas in England and Wales, and they were able to bring out themes around barriers to improving engagement, highlight ways in which we could better engage and manage their diabetes, and they highlighted the importance of understanding communication and building trust. There are 5 recommendations in that report, so I would urge you to read that when it comes out tomorrow. And finally, you may be aware of this study, which is still ongoing, which is led by Professor Tim Barrett in Birmingham. This is an NIHR funded project which aims to identify new ways to make diabetes management easier and more successful. And this study is still running, and I believe it's due to report in 2025. So I'm not suggesting that diabetes management is easy. It's extremely complicated, but we need to think outside the box, and we need to think about targeting those who don't do so well and think about why they don't do so well as some of the others. So thank you for your attention. Finish there.
Thanks very much, Justin. And apologies to Jackie because questions were coming through, but I think the Q&A was blocked, so a bunch came in. Some of them are probably best answered by Fulya. Sorry to put you on the spot later, but we'll do that after your talk, Fulya. Let's see. Yes, so Jackie asks, have we looked at the uptake of HCL systems according to age? So hybrid closed loop systems according to age. Yes, in the NPDA, we do an extended analysis. So we've moved towards a summary report, 10 pages. And then we've got the extended analysis that is on our website soon, and that is going to be published next week. So there's lots of information there, a lot of regression analyses looking at outcomes, usage. Yeah, we just exploded all the metrics that you see summaries on in our State of the Nation. So who is next on our agenda? Oh, we have Fulya, and then some difficult questions for you.
Thanks, Holly. Is it okay to share my slides? Would that be all right?
Oh, yes, of course. Tasha,
Thank
would you load Fulya's slides, please? Actually, while that's happening, I'll ask you a question if that's all right. Fulya,
Okay.
we've got how are people ensuring that technology that is funded through paediatric services continues to be funded and young adults continue to receive support required after transfer to adults? Does anyone have integrated commissioning models? Do you have anything that you could contribute to that?
That's a really good and important question, and it's obviously something that we're really mindful of as we're waiting for the NICE TA to be published. So the plan very much is that if technology is initiated in paediatrics, that it gets continued in young adult services. It's very much something that is on our radar that we need to be aware of and looking to find solutions for. But I think as we're going to be doing a lot of work with ICBs to ensure that we get the funding model, the procurement, services set up in terms of ongoing support for insulin pumps, CGM and hybrid closed loop systems going forward. So I think it will be part and parcel of that work. But yeah, it's really important, and I know it's something we've struggled with previously, but it's very much on the radar and something that we're working on.
Brilliant. And I think that probably covers off how will the adult teams provide the same levels of care to 18, 19-year-olds through to 25 years as these young people experience in paediatric services?
Is that for me as well?
Okay.
Yeah.
Yeah,
again, another
Jackie,
very good.
Feel free to jump in.
Yeah, no, it's a really good question. We know that the funding and level of funding for services in young adult care is nowhere near what it is in paediatrics, and so many young people will experience a sharp drop off in the service that they receive. Not in Jackie's service, which is absolutely excellent, but we know that that's not replicated across the country. So I'm going to come on to it in my talk, but it's again another area that we're really focused on, developing the evidence base for what works in young adult care, and then thinking about what we can do from a policy point of view in England to improve young adult care across the board.
Brilliant, thank you. Yeah, it's just so stark to see that children, well, young people, they're being transitioned just as everything's getting difficult in terms of HbA1c and DKA. So yeah, it's great to hear that these things are really getting some attention now. So let's let you get on with your presentation. Tasha's loaded your slide. Would you put that on slideshow mode, please, Tasha? So we can move through. We lost Tasha. Oh, I think she's resharing.
Sorry, I'm just trying to get it up. Bear with me.
Okay, I'll try and answer another question while we do this. Have we compared outcomes in ethnic minorities who are not deprived versus white population who are deprived? Do we see the same poor outcomes in Black children, young people who are affluent? Are the outcomes related to ethnicity, i.e. genetic, or barriers to access care? Great question. And in the NPDA, absolutely, yes, we do. We do a regression analysis as well, just to try and work out the contribution of all the demographic factors or association of all the demographic factors HbA1c, and we find that the single biggest predictor is deprivation. And once you take deprivation out of the mix, yes, there's less of an impact of ethnicity, but we do still see an enduring impact or association with Black ethnicity. And then when we break that down by ethnicity and deprivation for each, it's a shame I can't talk and snip and show you a graph at the same time, but if you look in our extended analysis, and I'll just share a link to that when we send out the link to this webinar. If you've attended afterwards, you'll be able to see it. But of course, there are many exceptions to the rule. There are some children, young people of Black ethnicity in deprived areas who are still achieving excellent outcomes. There is a biological reason why a Black child or young person will have an HbA1c that is higher with the same blood glucose levels, but not of the magnitude that we're seeing in the analysis. So it's not biological. There are other factors at play, and the task is to understand what they are and respond to those. So yes, I see Fulya's slides displaying correctly on my screen now. Fulya, are you there? Do you want to present them?
Hi, Holly, can you see and hear me okay?
Yes.
Was given to somebody else. You're right.
Say that you're cutting out. Oh no, that's better. You're back. Sorry.
Is that okay?
Yeah.
Yeah. So thank you very much for the opportunity to talk a little bit about the Children and Young Adults Diabetes Programme. I think this webinar is fantastic. I think it's brilliant bringing together paediatrics and young adults and thinking about data and how we use that for improvement. So in terms of the Children and Young Adults Diabetes Programme, it's still a relatively new programme. We've been up and running for just under 2 years now. And I think one of the best things about it is that it's a collaboration between the NHS England Diabetes Programme and the Children and Young People's Transformation Programme. So we have fantastic leadership from Professor Partha Carr on the diabetes side and Professor Simon Kenny, who's the National Clinical Director for Children and Young People on the paediatric side. We have a National Children and Young Adults Diabetes Oversight Group, the main purpose of which is to bring all the key stakeholders together, ensure that we're all aligned around a national set of priorities so that we have the best possible opportunity to make progress in our key areas of focus. And you can see that all the key bodies are sort of represented on that oversight group. And we have a fantastic regional infrastructure as well. So we have our regional transformation teams and clinical leads across all 7 NHS England regions. And of course, they have a really key role in, turning policy at a national level into actually delivering on the ground to improve care for children and young people. The other thing to say as well is that the programme is a 0 to 25 years initiative, which again gives us a really good opportunity to think about transition, think about young adult care, and not just paediatrics. Yeah, next slide, please. Thank you. So hopefully everybody knows this now. I've presented it so many times, but always worth reiterating our key areas of focus in the work stream. So they are firstly to address diabetes health inequalities in children and young adults, with a particular focus on access to treatment technology, reducing variation in care and outcomes between paediatric diabetes units, improving care for those transitioning from paediatric to adult care, and also with a focus on young adult care within that, and improving care and outcomes for children and young adults with type 2 diabetes. Next slide, please. So I won't labour this point because Justin's already done such a good job of describing, where we're at the moment in terms of health inequalities. But this is just one example in relation to insulin pump usage of insulin pumps, where we can see a 13% difference between Black children compared with white children, and an 11% difference between the most and least deprived children and young people. And whilst we continue to see a year-on-year increase in children and young people using treatment technologies, these gaps are persisting. So it's a really important area on which we need to focus. Next slide, please. So from a programme point of view, we have been able to use the National Paediatric Diabetes Audit data to develop a dashboard to empower our regional teams to identify units where there's really good practice and we're not seeing that stark gradient in terms of access to treatment technology, find out what's working well and make sure that we share that practice. And then also identify those units where we can see that there are more health inequalities and where we know that some additional support and funding would be helpful. Working with our stakeholders, we were able to develop a menu of interventions, and we've now rolled out our inequalities funds to projects across all of England, across all 7 regions. Next slide, please. Okay, so this is progress of our projects so far. The funding was allocated in November 2022, and 14 out of the 27 projects are now complete. Equity of access based on deprivation and ethnicity across these sites has improved, and we've also seen positive improvements in health outcomes such as HbA1c, time in range. So this data is from summer 2023. We'd had 666 technology starts across the project sites, and you can see it's a mix of CGM, pumps and HCL. I'm actually at a Children and Young People's Transformation meeting today, and the North West have just presented a summary of their tech project. And just in the North West, they've actually had over 700 technology starts. So I know that this number is going to be so much higher by the time we get all of the data in from all of the sites. So I think it's been a really, really fantastic project. And of course, it's important to say that 60%, so a high proportion of those children and young people started on technology are from the, IMD 1 or 2 or an ethnic minority background. Next slide, please. So I think one of the key things is what we learn from these projects. So of course, it's important that we've made a difference in those particular units that have received the funding or have rolled out projects. But it's also important that we take a step back and think, what have we learned from this and how do we apply this going forwards? So there will be case studies added to NHS Futures, and we'll have qualitative insights from projects shared at our learning event in February. And we'll also have a comparative analysis on the impact of the gap in access, which will be completed in summer 2024. Next slide, please. So again, I think it's our next big step in terms of technology is the hybrid closed loop TA, and the publication of the TA is imminent. And this is going to be absolutely transformative for type 1 diabetes care in England. If you're a clinician and you're involved, you use technology and you've got patients on hybrid closed loop, you'll know that absolute transformative effect it can have. Of course, in terms of outcomes, reducing HbA1c, increasing time in range, but just the massive impact on quality of life where, families come back to clinic and they tell you they've slept for the first time in years. So it's going to be an absolute game changer. We're very cognizant of the challenge ahead. It's going to be a big challenge. The TA looks very positive from a paediatric point of view and an adult point of view, to be honest. The update in terms of rollout is that usually with HCL, usually with TAs from NICE, you have a 3-month you have 3 months to sort of come up with your plans for implementation, but it's actually been agreed that we'll have 5 years for implementation. I'm really confident that paediatrics will go quicker than that, because I think we're in a good place to be able to go a bit quicker. But I realise that not all units will feel as ready, and so there'll be lots of support available, and the networks and the regional teams will be there to help in terms of implementation. There's ongoing discussions about what funding will look like, what systems and so on, and Parthika has been working incredibly hard behind the scenes to make all of that happen, and hopefully we'll have more of an update for you all soon. But again, I think it's really important that the lessons we've learned from the technology funding projects we can use in terms of the how we roll out hybrid closed loop. Next slide, please. They are waiters behind me, just in case anybody's wondering. They're moving tables. Okay, so as second area of focus is reducing variation in care and outcomes between units and ICBs. I've just got a couple of slides illustrating some of the variation that we see. So this is an ICB level slide looking at care process delivery, and it's just so stark to see that if you're in, one ICB, there's 22% care process completion, up to 93% in another ICB. So there's a very clear opportunity for improvement here. And then the next slide. And again, this is Justin's already shared this slide, but in essence, this is looking at mean HbA1c across different paediatric units, adjusted HbA1c, and we've pretty much got a 15 millimole difference. So again, this is a really high level of variation that we need to tackle to improve outcomes across the board for children and young people. Next slide, please. So our key strategy for this is that we are developing a children and young adults diabetes GIRFT programme. GIRFT, Get It Right First Time programme, provides a national mechanism for identifying, understanding and addressing variation in line with the NHS infrastructure for improvement. And I know there's been a lot of change and a lot of reorganisation recently, but GIRFT is still a really key programme within NHS England. So it's fantastic that we've got engagement from the programme team and that we're able to develop this programme with them. The scope will be 0 to 25 years, which is fantastic when we think about trying to improve outcomes in that older age group as well, as Jackie's described the need for so eloquently. And the reviews are going to take place at ICB level, which I appreciate is different to what we've done in paediatrics before, but with the significant devolution that's happening in terms of healthcare and ICBs really being the ones making the decisions, I think it's fantastic that we're going to be able to get in there early and make the case for children and young adults diabetes and make sure that it's on everyone's agenda. We're developing a national set of metrics incorporating data from the national data sets. So obviously all of our national audits at a system and regional level, and that will inform the clinically led reviews. And then the data we made available for ongoing use in model health system. And we plan to, we'll have some pilot reviews probably towards the end of this year, early next year, and the overall programme starting in spring of next year. Next slide, please. So again, I won't go through the data. This is just data looking at what happens to DKA admissions during the transition and young adult age group. But again, there's just so much data that highlights the fact that this needs to be one of our key areas of focus going forwards. Next slide, please. So from a programme point of view, it's difficult to implement policy in this area because it's a relatively evidence-free zone at the moment. There's evidence for one or two things that does seem to work in transition, but we were pretty much starting from scratch. And so through bringing together a clinical group and reaching clinical consensus, we were able to design a service specification for transition and young adult care. And the key themes within that were around paediatric preparation, a carefully planned transfer, young adult specialist care services, and ensuring a whole population focus and that there's integration with primary care, because we know actually quite a few young people, particularly for type 2, are actually in primary care. Next slide, please. So as I'm sure many of you know, we've rolled out our transition and young adult care projects across all 7 NHS England sites. We've got 15 projects running. And whilst the ask has been, the key ask is to implement the service specification, we've also asked sites to be innovative in terms of developing what they think they need to meet the needs of their own patient population. So there's lots of different exciting projects happening, use of youth workers, social workers, outreach. So it's going to be really fantastic when we start to see the data and, finding out what works. Next slide, please. So, of course, we will have a very careful evaluation in terms of the projects. there's the impact evaluation around engagement, measuring engagements, clinical outcomes and wellbeing and experience through patient surveys and interviews, and then also process evaluation, because we need to understand how feasible the pilots have been, whether we can whether we can scale them up and so on. And so the data is flowing, with huge thanks to our pilot sites, because we know that that's a big ask, and it will be able to inform our policy decisions going forwards. Next slide, please. And our final area of focus is improving care and outcomes for children and young people with type 2 diabetes. We're seeing a huge increase in type 2 diabetes in the paediatric age group, and actually just early onset type 2 diabetes. Diagnosis rates have increased by approximately 60% over the last, well, probably since sort of 2015-16. But what we know about type 2 diabetes in the world of paediatrics is that for us paediatricians, it's a relatively rare condition. So there's often a lack of confidence in managing these young people. And it's probably one of those areas where on a clinical basis, we link in with our young adult colleagues quite a lot for that support in terms of managing these young people. The other thing we know for young people with type 2 diabetes is that they often have complications and quite significant comorbidities at the point of diagnosis. And while we know that we recognise these, our national spotlight audit tells us that actually we're not very good at treating these complications and comorbidities. Next slide, please. So our approach in this area of focus has been very much around education and training, and also developing peer support for clinicians. So we are developing an e-learning for health module, primarily targeted at paediatric MDT members, covering the basics of diagnosis, management, complications, medications, and care at transition age, including pregnancy. You'll be pleased to hear, Jackie. And secondly, working with our Children and Young People's Diabetes Network colleagues to develop a networked MDT approach, so that all clinicians of young people with type 2 diabetes have somewhere where they can go to share experiences, upskill, learn from peers, and then have more confidence in managing those children and young people, and lead to improved outcomes. Next slide, please. I think that might. Oh yeah. Oh, and then for the older age group, hopefully many of you have heard of the Today programme. So we know that obviously my remit's up to the age of 25, but actually the early onset type 2 audit has demonstrated that the majority of young people up to the age of 25 with type 2 diabetes are actually cared for in primary care. And so the Today initiative is an enhanced package of care delivered in primary care to optimise diabetes management, ensure that there's pre-pregnancy education and planning, making sure that we're treating comorbidities and complications. And so I think this is going to be really key over the next couple of years to get early onset type 2 diabetes on the priority list. And I think that might be it.
Thank you, Fulya.
Thank you. Thanks. Whistle stop tour.
That was, thank you, that was so much to cover. We're running a little bit behind schedule. So maybe if we go straight into the next presentation, there's a lot to digest there. Maybe you could have a look, see if there's any questions coming in to the sidebar. But Lucy and Lisa, are you there?
Hi.
Yes. Hi, are you okay? I mean, we're here until 2, but we can go on for as long as we want. Other people will need to leave. But are you okay? Can you stay for another 10 minutes? Because I don't want to miss anything that you'd like to share with us. Brilliant.
No, that's absolutely fine.
Fantastic.
We're not able to share our slides. I don't have that function, but if it's
share your slides. Okay. Has Tasha got your slides?
She has. Yeah.
Give me one moment.
That's fine. Okay. Thank you. Well, would you like to introduce yourselves while Tasha loads those?
I'm Lisa Rowe. I'm a diabetes specialist dietitian, and I've been seconded to what was formerly known as Southport and Ormskirk hospitals. They're now known as Mersey and West Lancashire teaching hospitals. And I'm joined by Lucy Unsworth, who is a diabetes specialist nurse, and we're both part of the transition pilot. So our hospital has been chosen as one of the 15 pilot sites.
You booked a room for me and then I've arrived, but there's no room.
I think the slides.
Thank you. So I do apologise.
I think we're still waiting. Fulya, if you wouldn't mind muting yourself. Fulya is such a pro. She's been presenting to us from a hotel. So yeah.
Oh, lovely. Thank you, Natasha.
There we go.
So if we could go on to the second slide.
Oh, hang on.
So we're just going to really give you a very brief overview in terms of where we're up to with our pilot project so far, some of the learning that we've had from it, but also just really to talk you through how we've benefited from the working relationships with both our paediatric and adult teams. Are we able to go to the next slide?
Oh, can
I don't have the option.
you not see?
Oh,
Can
could
you
you
not
do
see
it again?
them?
Do you mind?
Oh,
Sorry, you'd
yeah,
have to take control option and it's just disappeared.
Oh, sorry, bear with.
Sorry about this. There we go.
I can't get them to go full screen. Just a second. Oh, allow. Let's see if you can do that.
Can you
Does that
enable
work?
editing?
Is it going to let me do? Apologies, everybody.
Tasha, if you enable editing.
I'm trying to.
Well, even if we can't do full screen, don't worry, we'll just click through them. So just really in terms of where our transition pilot started, so in July 2022, we had full recognition in terms of our team starting the transition pilot, and we had our adult diabetologist, Dr. Simon Saunders, appointed. He has really good experience in terms of managing type 1 diabetes, those on pumps and technology, and young adults as well. And then in September last year, they appointed our transition nurse, which is Lucy, and she's been in post since January this year. March this year, we appointed both the dietitian, myself, and we've also got clinical psychology input as well as part of our transition program. And our young people are really lucky to have quite a wide range of skills and expertise and the clinicians that we have available to them. We've got Professor Mei Ning, who's our paediatric consultant, as well as Dr. Donatella Pintus as well, who helps in terms of our transition program. Our patients have access to a wide variety of paediatric nurses as well as our adult nurses. And as I mentioned, we've got input from clinical psychology, which they have as part of our paediatric team, and that follows them through now until the age of 25. We're also very fortunate to have a diabetes data coordinator who sends all the information through for the pilot project and helps to keep everything running really smoothly for us. So in terms of the aims of our pilot, we're aiming obviously to improve the transition from paediatrics to adults for our young people, and we're trying to make sure that that is as person-centered as possible. As we mentioned earlier, that this age group is a really difficult time of life, and that's without diabetes, and we're obviously trying to achieve the best outcomes for them in terms of things like their HbA1c, admissions, and just attendance within clinics. We're making sure that they're getting the structured education that they need in order to access our transition services and transition from paediatrics to adults. And we've got a lot of experienced clinicians in terms of helping with pump support, interpreting downloads and what's needed within that. We have quarterly joint paediatric and adult clinics that we do with them, and we also have a monthly MDT meeting as well. So in terms of our progress so far, we're planning to transfer 21 young adults per year as part of our transition program, and they transition at age 17 to 18 years old. We have a total of 123 young adults on our transition program. This year we've had 19 patients offered appointments as part of their transition appointments, and 16 have attended them so far. And we're starting to see that the data is improving. So in terms of things like our DNA rates, that's come down compared to last year, and we're are able to offer an increased number of appointments as well. We've got further transition clinics planned for December and again in April as well. And we're obviously submitting all our data as part of the pilot project. And I'll just hand you over to Lucy.
Okay, so just further to continue on what other good progress we've made, myself and Lisa attend the Paediatric Diabetes Clinic every week, and our aim in that is to see patients aged 14 and above so that we become a familiar face to them before they get to that age of 17 when they transition fully over to the adult care. all young people are offered a progress meeting with a psychologist, and that is to co-create with the psychologist a progress letter to highlight what they want the adult team to know about them and what their best hopes and futures are for their diabetes management in the future. We have spent some time with the psychologist discussing what we would both like, myself and Lisa, and the psychology. So we've agreed that we'll do a handover which includes both medical information as well as the progress letters. Myself and Lisa recently met with the Diabetes Youth Coordinator to talk about the exciting programme that they've currently got running for the 11 to 25-year-olds, and that reaching out to them to ask what support that they could offer us. So we're going to continue to work with them, and myself and Lisa are both going to attend the meeting, which is on the 17th, to find out how we can further help our young people. We've also implemented ways of keeping in touch with the young people, not necessarily just through text or phone call, by using what we call smile cards. And it's basically just a motivational postcard just to say, hi, how you doing? We're here for you. You're doing really well. And not necessarily just about the diabetes, but it can be just something that, you know, they've achieved in life, just so that they know that we're here for them. So we delivered our first transition event in the beginning of October this year. It was with myself and members of the paediatric team, and I've just got some photos here. And it was to deliver the education, the goals of education for 16 to 18-year-olds. So we covered lots of different topics on that evening, such as alcohol, well-being in terms of psychology, long-term complications, and we did a bit of fun, like with carb counting, about guess the carbs in certain foods that, you know, young people find more popular, shall we say. So the event was a really good success, and we had some really positive feedback, and we want to hold these events twice a year, and we aim to do our next one in the spring. So how have we achieved this? So myself and Lisa feel that we've got good working relationships with both the teams. Like we said, we attend the paediatric clinics weekly, but we're also there at both the adult clinics as well. We attend both the MDT meetings where possible, and like I've already said, it's just becoming that familiar face early in their transition journey, so that they know who we are, and that they can reach out to us from the start of that journey. The transition handover and the progress letters, and it's just the consistency in the advice and the care that they receive. Obviously, that event was the first event as a group event, but I have also been going out with the paediatric nurses and delivering some of the goals of education from 14 years upwards. So again, when we go and do those visits, the patients are already aware of who I am, and it's just being consistent in the advice that I give, as well as the paediatric nurses. So what challenges have we found? So there has been a few. So unfortunately, there is no HbA1c machine at the adult clinics yet, so we're still working on that, and we're hoping to get that sorted soon. The care is provided across 2 separate sites. So the paediatric care is all at Ormskirk Hospital, and the adult care is all at Southport Hospital. So for some of our patients, that's been a challenge in terms of actually physically getting there. You know, going back to what we were saying about health inequalities, it's about affording to actually come to the hospital, because Southport is slightly further away than Ormskirk. Myself and Lisa have had to navigate 2 different IT systems, because the paediatric and the adult systems don't talk to one another. So we are having to master both of those IT systems. Unfortunately, again, for myself and Lisa, the paediatric and adults MDT meetings are on the same day, which is today, a Tuesday, but they're on 2 different sites. So it's sometimes feel like we're trying to split ourselves in 2. I'm sure this will come as no shock to everyone, but clinic space, just trying to see some of those patients, it's trying to find space. Like I've said, currently at the minute, it's completely split. All the paediatrics is at Ormskirk and all the adults at Southport, but going forward, we would like to offer some clinics on different sites for the young people. But it's actually physically finding a room sometimes to actually do that in. And the other thing has been trying to ensure all our clinic outliers. So not only are myself and Lisa new to the trust, but the adult team in general is a brand new team that only started from January this year. So our admin person has been absolutely invaluable in trying to find those people who haven't attended clinic for a number of years. I've had people like 5 years who haven't attended since they've left paediatrics. So she has been an absolute godsend, trying to get all these people letters, text messages, phone calls to try and get them to come back to clinic. So that is, but it has proved difficult at times. And what are our future plans? As I've already said, it's continuing to work with Diabetes UK and their young leaders. We're going to start a quarterly electronic newsletter just to let them know who we are, where we are, and just offer some recipe advice, keep them up to date with Diabetes UK. Just again, another way of communicating with our young people. We aim to send that out next week in conjunction with it being World Diabetes Day. And the next one after that will be in the spring. And again, I've already touched on this. It's to plan our next transition event, which we're hoping to hold in the spring sometime. And just to continue to develop other ways that we can engage with this patient group. I've been really fortunate as part of this project. I've been able to have a mobile phone, which again, I think has been invaluable because my mobile phone never rings. Nobody ever rings me, but they all text me. So I just think that's been really helpful because without that and having to try and ring people or email people as I was prior to getting the mobile phone, nobody ever contacted me back, but they will send me a text message or even just a thumbs up on the text message. So I know that they've got it. It's just a different way of thinking with this population group. And then we'd also like to develop a handover for moving from my service, mine and Lisa's service, to the adult service, to the, if they're on a pump, it's something about going forward, what we can think about of making that transition smoother. And also looking, not only because we're part of the pilot project that Fulya touched on, doing the surveys and everything, it's looking at what we can use long term to maybe assess mental health problems. We have talked about potentially using the D-Star tool, but it's just, again, it's something that we're talking about. And then the next slide is quite a nice slide. It's just some positive feedback that we've had from some of our patients. So it just says, thank you, you've been an amazing support for us all. Thank you for the postcard. I'm trying and I'm doing really well. I'm proud of myself and can't wait to see my next HbA1c. Thank you for the postcard. It made my day. Meeting this new team was a breath of fresh air. Lucy and Dr. Saunders were both caring, knowledgeable and supportive. It was apparent they both have a passion for helping their patients. And that's it, really. And that's just me and Lisa in both teams. Thank you very much.
Amazing. Thank you so much for taking time out of what is clearly a very busy schedule, organising all of that and planning all of that to tell us all about that. I'm sure there are some things that those watching can take away. I'm just looking at the questions in the sidebar to see if there's anything that comes through. I know that Tasha can't push through questions while she's doing slides, so I'm going to give that a second. But yeah, it's great. We've still got loads of people with us, and we've only lost about a quarter, which I think is testament to how useful your presentation was. Let's see, we've got some new folks coming in. Fulya, yes, Fulya just says it's wonderful to see such lovely feedback and see such great comments. Yes, and it must be. And so thank you for sharing those with us. The other presenters, there's a couple of questions that have come in. If you wouldn't mind turning your mics on, there's a Fulya, you might not be surprised, there's another one about funding, and then there's one about younger adult services as well, the older to children, which is what I'm used to talking about. So let's start with a techie one. Will there be a central directive on technology funding? Currently, we're not allowed to start people on some hybrid closed loops due to local directives.
All I can say at the moment is bear with us. There's a lot of work going on behind the scenes to try and get all of this sorted. So yeah, I'm afraid that's all I can say at the moment. But
fine. Sorry to put you on the spot. But...
No, it's okay. I wish I could tell you more, but I just can't at the moment. But hopefully it won't be too long before we can share rollout plans.
Wonderful. Okay, now for everyone else, what role do you think primary care has in helping to support 19 to 25-year-old care for those less engaged with specialist services? Our pilot suggested key roles for non-clinical support workers and primary care DM registers, I'm not sure what that is, to identify and support these young adults outside traditional OPD clinic models. Jackie, do you want to take that? And then Justin, do you want to comment from a paediatric perspective on what works? Maybe.
Thank you. So what we've done locally is let all our GPs know at a local PLO event that we want to see all young people under 25, whether they're type 1, type 2, or don't know what kind of diabetes they've got. And we've gone searching for young people with type 2 diabetes with the extra funding that we've got. Thank you, Fulya. And have linked up with our retinal screening team. So sometimes GPs will register people even if they've not had screening, but they're registered with them, and then we've been contacting those young people saying, you're very important to us, we care about your diabetes, but we want to help make things easier for you. So and we've been seeing lots of those type 2s under 25 that we've not seen before, so that's been really helpful. We have some people that won't come to clinic, so we're saying, well, we could meet you jointly at the GP practice, or I don't mind, if it's in a coffee shop, but most people have taken the invite up, interestingly, and have had a significant other come with them, and then there's a handful which we'll need to go back out to and try and meet them on their turf, at least to have one conversation about the kinds of things that we can offer. Moving forward, GLP-1s will reappear on the market, and there's a new GLP-1 that looks fantastic. So I'm trying to encourage people, look, you need to be in the system so we know about you, so that we can keep you up to date with the latest offerings, because things are getting better treatment wise, both in type 1 and type 2.
Thank you. Okay, right, well, we are quarter of an hour over time now, so maybe it's a good opportunity to leave and go have some, well, for us, go and have some lunch. I'm sure everyone's snacking away at home, but thank you to all of you for taking the time out of your busy days. Where are you, Fulya? You said there were restaurant workers behind you. Where are you?
I'm in a hotel in London at an all-day meeting, and I'm in a possibly a bar, who knows?
Thank you so much. Brilliant. All right, great. Well, we'll send a link out to the recording of this, and we should probably include some links to NPDA reports, NDA reports, and most importantly, probably for this webinar, the paper and the reports that we do together. People in the NPDA might not know that all the data that you painstakingly send to us, we also share that on to our NDA colleagues who do wonderful analysis looking at care and outcomes pre, during and post transition to adult services. So there's a life to the data outside of the NPDA as well, and it's really great to see the most being made out of that and the lessons coming out of that we've shared today. So I'll end there, and thanks. If you've got any other ideas for things that you'd like to do with paediatric young adult colleagues, let me or your NDA colleagues know, and it'd be great to see you at a future event soon. Thanks a lot. Bye.